One.
Okay, good morning and good evening, various time zones. Dr. Afzul Rahman and our all
Yes,
panelists and moderators. Can you see us and hear us?
yes, we can see you very nicely.
Beautiful. All right. So we thank our Boston Scientific and of course our Indian colleagues to give this chance, and I welcome all our the panelists there. So if it's okay, I just start our presentation. Always try to show to the next level, and so this basically is our expert panel with Ajay Swami, Kesava, Manoj Ravi, Karthik Vasudevan, Shailendra Ganjawar, and Sundeep Banerjee. So this is our the event, and this actually is now the live case number 19. So we have been doing 6 cases per year. This is the 4th year now for Meet the Masters. So try to show some complex cases, and this patient is a 68-year-old who had a angina positive and had a one vessel bypass many years ago, and since then at that time had a PCI of the RCA. Now comes back with positive stress test and has a Lima to LAD was good, and now has basically low ejection fraction, lot of other comorbid conditions listed there, good medical therapy, and patient had an angiogram which revealed RCA lesions, calcific, which is the point of discussion today, and there was a big diagonal, and the Lima to LAD was good. EF about 40%. So this patient also had DVT, for which patient is on rivaroxaban, Xarelto, and was discharged home on clopidogrel 75 and rivaroxaban 15 milligram. So that's the best combination with the Pioneer AFib study. So those time many people still give
Get
aspirin
us
for
FR
about a
guide.
month. Recommendation is give 1 to 4 weeks aspirin in these patients. Some people
You know
do,
what?
we don't
It's
give
a
it,
6-7
and
French.
we'll have a part of discussion. So this patient now is for high definition IVUS guided complex PCI of RCA and RPL2 using rotational atherectomy and cutting balloons
Is that
rotacut
a
approach. But more importantly, that use the Godzilla to advance the rota bud to the calcific RPL2. RPL is about 90% lesion, and we'll show that. And question was, and even part of the India Live when I was there were a lot of discussion that how can we advance the burr in the distal part of the vessel, and we showed some, and I think this was the ideal case for that purpose, basically.
Do you have 3D
That
RC?
show it with the
7
that
French.
how we can advance the rota burr distally, and from appropriateness point of view, this patient is appropriate because of multiple, more than 2 anti-anginals and patient ischemia, so appropriate. And then from the guidelines point of view, as you know, there is no class 1 indication of any devices yet because the trial still has to show that they are positive. So 2A is the only one we come with a rotational atherectomy, orbital and others, laser, they all are 2B. And lithotripsy also, although lithotripsy soon might make to 2A. And latest trial of the Eclipse, which was for orbital atherectomy, so no, being a negative will not go up. So I think that will remain 2B. And so that's where we are now, and we are going to show. Anu is just taking the picture. You see the calcium already. Go to the fluoro now, please. So calcium everywhere in this vessel. Look at that. Difficult to engage. And so this is the 7 French mark guide we're using. Did we use any other? What use early? This one is a Lima.
No, we just used
Lima guide?
FR.
What is it now?
This is a Lima.
Lima guide, yeah. So it's a Lima guide, and the question is, should you use AL 0.75?
It's not going to.
Yeah. So look at the AL 0.75 also.
No,
There's no
it's
7
not
French
good.
Akari.
With there? Okay. Why did we get side hose?
Yeah. Okay. I think this may be okay.
No, but it does not stay.
Yeah. No, but once you advance, this will go further.
Okay, get us a fielder fine cross quickly.
Okay. So you want to tell us, Anu, the diagonal which was done, we took the picture, which is fine. Lima to LAD is good. Circ has moderate disease, but a lot of calcium in this right coronary artery, as you can see here. And what we are going to see whether there is a luminal obstruction or it's a more of a in the deep or superficial calcium. So that's what we are going to see. IVUS is ready in this particular case.
No, I need the fine cross.
And, yeah. And
Can you
want to
check the
emphasize on
BD?
that RPL too. You have to point to what we are doing.
Wait, let me just see.
Can
So
we see the blood pressure?
yeah. So you show the
We can put the
hemodynamics.
hemodynamics in the side there.
We are
Yeah.
going to do that. They will show it hemodynamics in the
Okay,
bottom.
so
Yeah.
here we are. It's a significant disease in that RPL.
Yeah.
So the stent in the proximal RCA, mid to distal RCA. So a lot of disease in the distal branches.
Only question is how, and we know that advancing any devices could be one, cause more trauma. Second, we may not be able to advance anything. And that's what we felt. You see the calcium at 6 o'clock position, origin of that long RPL AV continuation. We thought that you need to do some atherectomy in that particular case because even IVL, in my opinion, will not make a turn. Will not be able to go down. So goal here is we always had to say our plan first. The plan here is 7 French guide. Use the
Get us a 7 French Godzilla.
and then go with the 7 French Godzilla and advance that over the balloon further down up to the mid RCA and then exchange for the rota wire. And then idea is that we can get rota burr. Lot of people say that can you put the rota burr through the 6 French Godzilla? Answer is no. Some people have tried it. We have tried so many times, does not work. Only thing you can get through the 6 French Godzilla or guideliner is your orbital atherectomy, which can go about 70% of the time. But rotablation, even 1.25 will not go through the 6 French, and they actually have a lot of you front load, back load. But I would say that if you are trying to do using the Godzilla guideliner, use 7 French, and that will help you to advance this small bar. Actually, even 1.5 can go, but it has to be the 7 French, not the 6 French. Your guide has come out as very poor support, but we'll try to see what need to be done if this guide still continues to be bad support. So if there is no 7 French hockey,
Which one?
Akari guide,
no,
right?
No 7 French Akari. There's no 7 French 3D RC either.
There is no 7 French 3D.
I mean,
You know, many of the things are
we don't
nowadays
carry.
on the back order. So I'm sure we are having the same problem in India also. Many things are back order. They're not available. What could be the other 7 French? No 7
No,
French.
I think
no
other
top.
one is just go with FR, right?
No, FR will give you no support. I would say go
No,
with the
if you are going to use a Godzilla, I mean...
AL 0.75. I think still will try AL 0.75 7 French.
No, it's once you have this kind of a
Yeah,
situation.
so we tried the FR apparently first, did not work, and now it's the...
No, we did not try FR.
Okay.
Hold the...
So this is the only one we are going with that now.
Sometimes preloading the 7 French Godzilla.
Yeah, that we are
We
doing.
already have preloaded
Then
it.
wiring.
Yeah.
Yeah.
That's exactly
so
we are
maybe
doing,
if
yeah.
you just get a wire in, sometimes the Godzilla will sit.
Yeah. That's exactly
In this,
being done.
in this kind of a situation, it's very hard maybe even to get it down. We may need balloon support. No, don't move. I don't want it to move it.
And we'll use the extra support wire here. Rota, usually we use floppy because cause less wire bias. But in this particular case, you need to get things down further. I would go with the rota extra support when the time will come. But we are a little far away from that because we still have to get the wire distally, get our over the wire system further. Why? Even this one is not going. So tight lesion in the proximal.
No, it's not tight lesion. It's the...
No, none of that. Yeah, it's clearly the case of very poor guide support. Yeah. No, but
Maybe a balloon to pass the guideline at the side.
No, but right now we have...
no, advance the guideliner now. That's the question.
No,
we have some balloon here ready.
The guideliner is not going to make it.
Okay.
It will just kick
Give us
the guide. If we try to
3.5,
advance the guideliner now, it will kick the guide out.
Right. No, but question is if you get a balloon.
Over a balloon.
Yeah, but we already have a fine cross here.
Okay.
We cannot change to a balloon
Right.
now.
Right. Good. Let's see what happens. Get the balloon ready. Yeah. Okay. Well, making some good progress.
Can you hold the guide?
Yeah. Yeah. See, but this is a fielder wire.
Yeah.
Yeah. The fielder wire. Good.
Maybe you could manto the manto the fine cross and put in a balloon to get the guideliner in.
Yeah. So that definitely will be the plan. Yes. We had to put the guideliner further down and slowly inching with the. We actually had two fellows here. I did not introduce them, Jason Kaplan and Swati Rao, of our 8 international fellows, the 2 of them. And we have Will and Alina, our RNs, and CVT Asif and Habib, and imaging is Kiski, as usual. So is it the second vessel?
Yeah.
Or the first one? You want to see it?
I think we're okay. Okay, hold
Yeah.
on.
So the wire has gone.
Let's
Yeah,
see
and
if
then
you
the
can-
guideliner is coming now. I think there is some disease at the ostium which we did not appreciate
No,
earlier.
it could be the stent is
Calcium. Yeah, it's
sticking out also.
Yes.
Okay, ready? Let us see. Show me some dye. It's good, Assis.
Yeah.
Wiring is okay.
Okay, wiring is all right. Yeah.
The only other question is you want to go side by side and with
No,
the balloon.
I
and
say
then-
here, put a long exchange length run through and put a 3.5 balloon to ostial opening, and then advance your guideliner further. I think there's something is at the ostium. What exactly it is, you'll be able to see on your IVUS, right? Can you advance now or no?
Forget I was there.
Okay, so at least one victory there, able to get the fine cross across the lesion. So that's a good thing. So now question is simple. If you do only rota, you'll have a little trouble to advance the guideliner. Good, just okay, you're further. You're enough.
Just saying use a, I think floppy wire, no? Rota floppy wire.
Rota floppy now?
We can do rota floppy. Then side by side, let's go with the fielder and get a 3.5 balloon and then get the guideliner in.
Okay. All right, so that's okay. Let's do it.
Otherwise, you have to again change it to, yeah, get us a rota floppy wire.
So the question is what
Three
type of
loops,
wire
three
we
loops.
use in here to get little further support. See, very calcific. I would say that in the extra support region here will be, it's not going to cause any wire bias because so calcific
Okay,
vessel.
get rota extra support.
Yeah, I think we go with the rota extra support because you need little extra support into the body of it. And then Anu's idea is that after that, we put the fielder wire which we have and put a balloon
Get
and
us
try
a run
to
through
get the
and a 3, 5,
guideliner
12.
Godzilla in there.
Get us a
The
3.5
7.5.
12 balloon.
We have it.
You
Yeah.
have, okay.
Yeah. Okay. So now we are changing to the rota extra support wire. Okay. Always clean the wire out because there is a lot of debris on this wire. I always say that you have to take the wire out from the hoop and clean it.
No, 12. You have track? Track or no? What is it? 2.5 watt? 3.5 watt? Oh.
But use the compliant then right now.
No, do you have a compliant 3.5? I think we don't carry 3.5 compliant.
3.5 we have. Get a 3.5 12 or 15.
Okay,
Good.
keep holding.
Yep. So now we are exchanging. The wire is quite distal, which is good.
So this one we are not going to make a loop. We're just going to keep it straight.
You want me to?
Normally when we remove the fine cross, we can stand there and make a loop. In this case, we will go straight. Don't pull too much.
Mhm.
Okay, now you have the run through ready.
Run through a fielder. What do you want?
Okay, get us that fielder itself, right?
Yeah. Same fielder which you have. Good.
I do it.
Okay, so now rota wire has been advanced, and we have the 1.25 bar ready or there, or what we have? Nothing.
We didn't open.
Yeah, get a 1.25 bar, but first thing first.
No, don't open.
Yeah,
Let's make
we
sure
have to
that the
advance the
Godzilla.
guideliner
Yeah.
first, the Godzilla.
Yeah. If that does not go,
Yeah, good. Balloon is ready. Okay.
now we have to see.
What's the rationale of keeping the TPI
Huh?
lead?
Yeah, so I mean,
What
in
is the
this particular,
rationale for keeping the TPI lead in this case?
yeah. So the question is that one, when we want to avoid, you can always give aminophylline atropine because this will going to create a lot of debris. But in this particular case, the usually, I mean, I would say the moderately calcific lesions, those aminophylline atropine combination works very well. This case will develop tremendous asystole and bradycardia. Once we'll do rota, because once you go across the AV continuation, that's a very common event, and that's why we are doing put the temporary pacemaker. Now, can you avoid it if for some reason patient has a venous issues, and so yeah, then you just have to rely on your the aminophylline, which is 300 milligram, and atropine 1 milligram you give. So now the wire actually have a little destroyed, which is not uncommon. You have to go to the new wire. Yeah, and go with the run through wire then, right there.
So this was
Yeah, that
destroyed
always
first
happens
time.
because once we have to direct it when it is coming out from there.
No, we looked at it, but the thing is, I think since we used it already
Yeah,
once,
yeah.
it
So
was.
that's so clearly. I hope we can ask actually audience that whether people will use the temporary pacemaker in this particular case, or will just rely on chemical coverage of aminophylline and atropine. I think that's a good one. And we told you our reason for that opinion, that why we think that it should be done. But yes, now if this case is being done by radial, and that's where we definitely want to avoid the venous cystic and all that. With that case, maybe you can do without it. Okay, get your balloon ready. So you see that side by side balloon is there. Yeah.
3-5 don't exist.
Yeah, 3 years, okay, 3 years fine. Yeah. So we'll take the balloon distally, anchor it, and get your
Godzilla
in. And do you want to do IVUS beforehand or no?
I would avoid IVUS for now.
Okay. Unless anybody in our panels want to see the IVUS. But I think my only biggest question here is that what is going in the ostial RCA? Now we are seeing it. I think there is either very calcific plaque, which is moderate, or a stent coming up to and making the angle different. Because you are not able to advance your Godzilla there.
I think it's a stent.
A stent, okay.
Okay. Okay, now
That's okay.
go inflate.
You
Can
see
you
that?
have a stent boot at the ostium?
Sorry.
Can you have a stent boost at the ostium?
Yeah, we can. Yeah, I think with the balloon, open the ostium first before you go in.
Down.
Yeah, deflate. I think the ostium we had to do. So get the stent boost once the balloon is there. But we have to collimeter, but
We may not be able to see it.
no, collimeter will be okay. But anyway, we are going to open moderately ostial RCA. Yeah.
Okay,
Yeah.
go up here.
The question is it a calcium or is it a stent? That's the question they're asking.
Neither. Go. I think there's a stent. There's no disease there.
Okay. Now advance the guideliner. Yeah. Yeah, it looks like that there is no
Keep
stent,
holding, keep holding,
but
keep
just very
holding.
calcium. And now we are going to advance the Godzilla on this balloon there.
Oh, you know what you guys did? You gave me a 6 French Godzilla.
Why?
No? Is it 7? Okay, okay. Good. Okay, that's fine.
Yeah, 7 French.
Okay, keep
You
going.
need the
Keep
7
going.
French, yeah.
Keep going. Inflate. Okay, deflate.
Wow.
Also, we have noticed that once there is a stent, advancing Godzilla is not that easy.
No.
We may be able to do rota without.
Okay. Yeah. So see the change in plan. So even Godzilla doesn't go. So something
Go up here, really high
calcium.
pressure. No, it's just, I think, the way the angle is.
No, you have to
Keep
pull
going,
back here.
quick, keep going. Keep advancing, keep holding, okay? I'm going to advance. Okay, keep going, keep going. Okay, deflate now.
It's probably, if the balloon is not going, take a boost, because it is unlikely to happen. But if there is a stent and we have gone through the stent start,
Yeah.
behind the stent start, unlike, but
No,
just a
if a balloon is going, there's
Yeah,
no way
balloon is
we are
going.
behind the
See?
stand
Yeah,
start now.
balloon is going. Yeah.
Yeah.
No, ostium, pull back. You have to get to the ostium, half coming out. Yeah. Go here, 20 atmosphere.
Yeah, I think this is where you
Yeah.
have to balloon, because the balloon is slipping away.
Yeah. Good.
Okay,
Now
go.
deflate. Good. Now went in. So ostium was the trouble.
No, it was not ostium.
Yeah,
I
but
think
that's okay, yeah.
half stent
Yeah.
was, I mean, half the balloon being outside,
Yeah.
it just facilitated the movement. Yeah. Okay, now hold on. Go up here. Okay, now we can have the 1 to 5 bar ready.
Yeah. Get the
Okay,
1
down.
to 5 quick. Yeah.
Now down.
You saw that step by step, and this actually we want to just emphasize. So right now we just have moved the Godzilla, so balloon and the wire we are removing. Just go to the slide again, so that this steps, because they, as I said in the India Live, in 2 of my presentation, people ask about the steps of advancing. Go to the slides again. So we have made it good. So this is basically,
Keep it.
this was the first slide
Yeah.
Yeah.
Hold on.
that we
Let me
talked
see.
about it. Yeah. This is the set.
Yeah,
Yeah.
that's the first slide. That's today's case.
Yeah.
Question is, how will we advance now? Yes, ideally we need to probably have imaging. If you don't have imaging, you can do angiography guided assessment of calcium. So once the rota is there, of course we know it has to be just pecking motion, slow pecking motion. The question is, how do we get the bar down there? So go to the next slide.
Yeah.
So the first step is, so we showed how we get the Godzilla all the way down. Suppose you need to do it without help of a Godzilla. Suppose we are going to do distal RCA, PDA. So you see the whole, if you can come to the ceiling camera, also show the ceiling camera. Yeah, bigger. We have to be faster here with the Godzilla down, right? Okay, yeah, this is where we are. So this is 9 centimeters, which is 90 millimeters. So that's all you get the burring. So when we are saying distal RCA, PDA, AV continuation, we lose this. If we are just doing burr from the proximal RCA, we are already beyond 9 centimeters or so. So what we say is, bring your knob a little bit further, which is about a centimeter away from your proximal area. Okay, the very important is, you see that if you leave it loose, this will be moving. So what is this movement? This movement is the movement of the Teflon sheath on the burr. So we have 3, right? We have the wire, the burr, the Teflon sheath. So this is the movement of the Teflon sheath. So we make sure the knob is nice and tight. Okay, so let's go back to the, hey, SS, we have to take this out. Oh yeah, there. Okay, now go back to the slide again.
Yeah,
So now leave this ceiling camera. Oh, you can't show both, right? You can show the ceiling camera and the side. So the first thing you do is tighten the black knob. The first operator does it. The second one is brake release, which is here. Can we go back to the ceiling camera or no?
Yeah. Ceiling
Oh, yeah,
camera,
good. So this is the brake release. So what does the brake do? So this is the brake. The brake holds the wire in position. It holds the wire in position so it does not spin as a rotor happens. It does not spin inside the vessel. So you need to do a brake release so the burr can move easily. Okay, so The second operator will do have a brake release and then hold the wire with this little tug, so that doesn't move backward forward. That's done. And on the dyna, which is here, the third operator will open the 2V and keep going forward here.
Okay, so 1 second.
No,
Why
not
we are
third
not
operator.
there
I mean
yet?
the operator, not third.
Yeah.
The third step, which is the operator, will
Yeah.
be moving forward. Those are the 3 steps.
So this is very important. We made this special slide for this particular purpose. Okay. So,
Andrew is here, so we probably can make a video of this description that
One
we
sec.
just did also.
yeah, no, you put.
Okay,
you
put
it.
the
Yeah. Check
test.
the speed same way.
This is a 125 bar.
Good. Okay,
Okay,
let's go.
you're going.
The same.
Yes, back to fluoro.
Yeah. So until there, you go regular way. Push and pull till you come to the ostium. So we couldn't hear the question. Can we repeat, Dr. Rahman, the question was asked? I think there's some question was asked by either panelist or
Yes.
some audience. Yeah.
None of us
No,
heard it
I-
either.
So I have one more question. Why not do the IVAS? You are willingly avoid it?
No,
Why
we'll do
not
the
do the
IVAS.
IVAS
Yeah.
first?
No, no,
Yeah,
we'll do
we'll
the
do it
IVAS.
later.
Yeah.
Yeah.
We'll do the IVAS.
Okay,
IVAS is
okay,
ready. But question is that we know so calcium, so difficult. You saw that everything. So we said, let's
What-
just finish this part and then we go to the IVAS. We'll
So
do
you
the
see
IVAS.
that look at the how the blood pressure is right now. You don't see much, right? So we do our 3 steps. We probably don't need to do the dyna. Let us
Yeah.
see.
Yeah.
Okay. No. Hold on. Let me go.
Yeah.
Okay. Let's do it here. So we're going to do that dyna step again, so that we'll be able to go to the distal vessel. Okay.
Yeah. So we tight here.
So same tight here. Okay. So you have on the dyna, if you can see here.
Yep.
See this is on the dyna.
And
He's
we are
going to do the brake release
and go advance.
and press
yeah.
the dyna.
Yeah.
Press. Yeah. See, this is now. You see me, I'm advancing manually. Can you see my fingers
Yeah.
here?
Yep.
Yeah,
Good.
yeah, good.
So stop and then. So that way you advance the bar. So I'm glad that we are able to demonstrate exactly what we have been saying and in the slide.
So we are at what, 145, 150?
Yeah, 150. Yeah.
Okay, good.
And see that pacemaker rate?
Okay,
See the
come on.
pace? So key is that this
They're coming
case
out.
we knew
Come
that
on.
is going to develop. See that? Yeah. So that was the reason, logic behind was our temporary pacemaker in this particular case.
I want to bring the Godzilla out.
No, wire.
Oh. You.
So fast.
Okay.
Yeah. Okay, the wire has come back a little bit, which is okay.
Give us a run through wire.
Yeah.
Let's just quickly go through it. I think maybe I was pulling it too fast.
Yeah. Okay, so let's put a run through wire
I'm
and
going
then
to
we'll
go
take
with
a
the run
picture.
through wire and then
then-
we take a picture,
Yeah.
right? Now we have to be, look at we have some blood pressure that's being shown, right, in the side, yes. That's because of the Godzilla, we have some damped pressure, so you have to be very careful when you take a picture with the light pressure, not to inject too hard. Any questions so far?
The pressure is not too bad,
Yeah.
Dr. Sabin. This
Yeah,
is
that's right.
Rajesh Swami.
Yeah,
Maybe
so-
we can leave the Guideline here and put the imaging catheter through this.
Yeah, that's what we are going to do now. Yes, absolutely.
That will be easier.
Okay. So now question is, we have the fielder wire ready also because run through because of the tortuosity, because
Let us see if we can go through the side.
So, yes, Guideline will help to get all the devices, whether it's a rota, stent, or IVUS. Huh? Yep.
There's some background noise.
Yeah. Good. That's fine.
We appreciate your decision of putting the TPI in advance. The only concern
Can you
is
take a picture? No, take a picture.
the nuisance produced by TPI lead
that
in
is
these
true.
complex cases.
But sometimes
Slow,
they may be
slow.
helpful too. But yes, clearly there is always a trade-off. What we do, that we do what is essential, and there's no reason to do unnecessary things. But I would say that it's kind of TPI in this kind of situation where you have the Guideline obstruction, decreased blood flow. I think it's reasonable to just do it so that one part of the equation is out.
Yeah,
Exactly.
and the more importantly, if you have done this thing in this complex case, and if this patient didn't have this support, giving atropine, some massage, asking the patient to cough will bring out all the gadgets, and you have to repeat the whole thing.
Yep, exactly.
Can we show the IVUS on the
Okay,
screen?
let's start the IVUS.
Yep.
Okay, let's bring the IVUS on the main screen.
No, side is good.
So it's not
IVUS.
Okay, start feedback. It's coming. It's a distal RPL. Yeah, here's a
Wow.
lot of calcium.
Yeah.
Looks like the surface is shaved. I'll come to the bifurcation.
good.
Yeah, diffuse calcified lesion. But proximal part is open.
This is distal RCA, Kiski.
Yes.
Okay.
Okay, it's come to the guide zero. We didn't see the
Flush
stent.
it again.
Okay, let's understand what we saw.
Sure.
Give the balloon.
So
we
first, the
will
start
have
of the pullback. It's like a 2.9 vessel.
3 or 20 high pressure.
Yeah, and this is like looks like the surface of the
So
calcium
what
is
do we do with
shaved.
this branch?
Like
320 high pressure.
180 to 270 calcium.
Side branch?
Yeah, I see some
worry
small branch here.
3 or 20?
Yep.
This
No,
is
we have
another
a 12, no?
branch.
We have a 3 or 12.
We have a 3, 5, 15.
Oh,
Hi,
okay,
Dr.
that's for the proximal.
Yes.
Yes.
Like a calcified nodule there. Would you like
Yeah.
to put more?
Go back. Where are you showing calcified nodule?
Yeah, if it's protruding inside, we can call it calcium nodule.
Yeah, where is exactly that one is? Yeah.
Might be here, but it's like the surface of the nodule is shaved by the 1 to 5 loader. It's not like a protruding
Let's
too
use a
much.
cutting balloon today. Actually, total cut.
And native like a 180 calcium.
Yeah, this one. What is that? Oh, wow. So I think we should use a cutting balloon now, and that was the whole plan, was to do a rota cut approach.
Yep.
So what is the lumen here? And it's a circular calcium. Where this is exactly? Do you know?
2.5 cutter?
Or 3.0?
Yeah, vessel size is actually 3.0 vessel.
Then maybe go 275.
275, yeah.
So wherever that
Nodule wire is.
Yeah, I think this is the bifurcation.
But except one area, I don't see the circular calcium, right? I
no.
not three-
Wherever we did, the tightest lesion had circular calcium right there. I mean, at least three quadrants.
Yeah, 3 quadrant. I think
Yeah.
it's 3 quadrant, not 360.
Yeah,
Like
3 quadrants.
270 calcium.
But 125 bar actually has done.
I think so. Like here, a very tight calcified stenotic lesion, but we did shave after the loader.
And had to put a synergy stent.
Okay.
Okay, so now we are going there now. It need to be, I mean, this time you can pull back the pacemaker if that's what you want to do. No, too far, way too far.
Wait. Yeah. I can't see it. Yeah, right there. Okay, go.
So 14 atmosphere. Don't go more than 20 because I know a lot of people start going with the Wolverine, with the Wolverine and more
18
than
to 20. Yeah.
Yeah. That not more than 20, because then you start having the
I wanted to show
perforation.
that it fully expanded.
Yeah, so just little proximal. That angle lesion is here. Pull back a little bit.
I don't need that. Okay, then you want
Yeah,
3O,
yeah,
what
this one.
length?
That's 28 or 24. Yeah,
Longer.
so this is now at 16 atmosphere.
You'll need longer,
Cine?
at least 32.
Okay. 3032 synergy XD.
Okay, down.
So this is good.
Yeah.
Pull back and just go back again to the distal segment. This is where the more calcium was.
Yeah,
Yeah.
do you ever consider agent for this lesion, as this patient is already on a NOAC and a single antiplatelet?
That's a good point. So I would say that, yeah. So, we have the trials ongoing at present for the native vessel. For ISR, of course, we know these agents are quite good. But for the native vessel, we have only a small vessel trial. Because the feeling is, if the vessel is more than 3 millimeter, probably those agents, the DCB may not be the right approach. I know there is a whole country is going with the DCB approach, and we actually have a nice review in the JAMA. Overall DCB used in the world is anywhere from 2% to 32%. America is 2% and Europe is 32, particularly UK. But we still have not developed the full faith on a large vessel DCB. I know a lot of people, large vessel side branch DCB, there is one small trial, did show some benefit.
Don't connect it.
But we still need to have a full confidence on that point. So we'll use it in a small vessel. So this definitely is approximately almost 3.5, right? What was the vessel size?
Yeah, proximal part is like 3.5.
3.5 and 3.0. So this one, we will not go with the agent. Although agent in America so far has only been approved for ISRs, not for the native vessel. But we are on the trial of the MAGIC and the solution. Both are sirolimus. Small vessel trials are ongoing. And we are part of both the trials and have highest enrollment. Good.
So the two branches, let's try to avoid both.
Yeah.
Okay.
The question is, yeah.
One we can jail, let's not jail both.
Okay.
Okay.
Want to see the picture? Or?
Okay. Slow. Good. So if you pull back,
2 millimeter.
Then you will have two jailed branches.
No, just one branch we jailed. So very important point. Yeah, we're going up now.
Yes.
We have 3.5 balloon there. Bring it here. So this is 14 atmosphere. This is a synergy XD 3032. Yeah. 1 second. Going again. Now, question is how long you want to keep that Godzilla, or you want to take it out?
If we take it out,
yeah, it could be a trouble.
Yeah, then will be a trouble. No, the thing is based on the angio, right?
Yeah.
Where else you want to intervene?
At 8 o'clock position and maybe ostium. So I think we have to do, after we deploy the stent there, we did post dilate, and then we do IVAS to decide any other area is hemodynamically significant. To us, only ostial appeared only today. We did not appreciate that earlier, the picture which were taken.
I don't think there's any significant lesion elsewhere.
But to me, at a level of 8 o'clock, in that angle.
Let us see.
Yeah.
IVAS is ready, right?
Yep.
After this, we'll
clean out IVAS. Let's see. And that time we will bring back our Godzilla into the guide catheter.
What about a pullback physiology all the way?
Yeah, that's another good point with IFR, that where you see exactly where, and that you do with that also. So I think first thing we want to do, let's say hemodynamically, the lumen obstruction point of view. Yeah, good. Ready?
Yeah.
That IVAS is a good lumen, nice lumen, knowing that there is a good correlation of the lumen, IVAS lumen and FFR. So I think this is your point in this case require a lot of manipulation or investigation actually from terms of the imaging and the physiology. So we'll try to do everything to appropriately because this patient has already bypassed surgery and has a significant inferior wall ischemia and mild lateral. That from the diagonal, lima to LED is good.
Out now. That is not 3.5.
Yeah, That's fine. That's okay. We're done. Yep. Good.
Get us IVUS. So
Yep.
let us just do the IVUS and
Did we still have to take the picture? We didn't take a picture after the stent.
I think if you do IVUS, you don't need a picture.
Okay. Let's keep it there. Okay. All right. Going to the imaging right here. And the question is, you leave it there and then pull back. So we need to have two things.
First,
One-
we will, no, let us just image the stent and then we will do another pull back at your 8 o'clock.
Yeah, 8 o'clock and ostium. Two of them.
No, if you're coming to the ostium, Godzilla will be out. Then
No, we want it to be out. Yeah. That time.
advancing
Which
may
is
be
what?
trouble.
Okay.
Kiski, we're going back to the stent.
Yep.
I have a question, Dr. Sharma.
Yeah. Yes.
So let's proceed. We have gone through and through the stent in the ostium. Now, when
Yeah.
coming back, would you put stent there?
I mean, if there is some obstruction, yeah. I mean, I think it was just the position of the ostium versus, because we had a very difficulty. But I would say that if there is a lot of calcium and moderate obstruction or even the lumen about 5, I think it will be reasonable to do the ostial stent also in this particular case. But we'll evaluate and we'll have all the discussion. So, okay. Or
Okay.
show that.
Okay. I start pullback.
Yes.
Okay, this is a distal LPL, native. Okay. Transition looks smooth. Stent is expanded. Nicely expanded. Crossing behind. Yep. Now native. Mid RCA.
Okay. Stop.
Yeah, I will stop it. So first check today's stent. Yeah, distal edge is on the
Now we are
plug.
taking the Godzilla out.
Just after
You can
the
take the
stent is a
pacemaker out
lesion,
also.
but looks like
No,
not the
leave it.
dissection. No
Okay, I
dissection.
need it.
1 second here.
Yeah, proximal edge is just after the branch. And
Okay,
I'll
let
check-
us now do the
1 second.
IVUS
Yeah.
run.
For that
Yeah.
8 o'clock position, which we thought there was a lesion, we are doing another IVUS run.
Sure. Check the image.
Yeah.
Okay, start pullback. Huge lumen.
Look at the lumen, so big.
Mhm.
Yeah, I saw the castle nodule.
Yeah, there's a nodule, that's
Yeah.
it. But the lumen is big.
Yeah, because big vessel. Yeah, another nodule. Yeah, I see.
Yeah.
Okay. I stop it. I saw.
And now do the ostium. So we'll
Okay,
do
now
if-
let's confirm that, okay, with the level of the nodule,
Yep.
get us a CSA there. Yeah,
So this
it's
is a
big.
nodule, but
Yeah.
here is lumen is open.
5.5.
One
Yeah.
second. So this is looks
I
tight.
don't think we
No.
should
I
touch.
mean a lot of calcium, but area is like 4.7. The mid RCA. Here's also another nodule, but the lumen is open. So it looks the mid RCA tightest part is like 4.7, like around here. So a lot of calcium, but area is open.
So it's a lot of full circular calcium, but
Yes.
lumen is good.
Yeah, like, okay, yeah.
Lumen is 4.8 there.
Yeah.
Okay. Let's go to the ostium. I think then that's what it looked about 60% distal RCA. Now only thing left now is the ostium.
Sure.
So let's interrogate the ostium now.
Yep.
Okay.
Another one.
How many people say that there will be disease?
So guys should
If
be
the
out.
stent is outside the vessel, might have
Yeah.
deformed the stent by putting this guideliner. So maybe, but we need to assess whether the stent has been crushed.
Yep. That is correct. So we'll be able to do everything now.
Dr. Sharma, I am regarding your rotated study. Now you used a cutting balloon.
Yeah.
When do you think you will use a regular NC balloon? When do you think it was a negative study? There was
Yeah.
no
So
significant
very good point. So I think from academic point of view, there is no reason for us to use cutting balloon. We have done the
Okay,
rota. In
start
this
over.
case, we just
Yes,
wanted to use
coming.
a very small burr we use. Okay.
Yeah,
Now let's
I
see this
see
now.
Oh,
stent. Here's a
stent
stent.
is floating.
Yeah. But lumen is okay.
Ostium is okay.
Long stent. Yeah.
No.
Okay. I will stop it.
Okay.
Yeah. Just the ostium.
Is there a disease there?
Yeah.
Just the ostial
So
part.
yeah,
just the ostial
yeah.
part.
So this is the exactly ostium of the RCA. Just very focal, but looks tight.
But it's there. There's no stent in the ostium, right?
So 1 second. There's a lot of calcium. It's hard to identify.
There's stent in the ostium.
Just
No.
after tight lesion, I see
Yeah.
some artificial dull.
No,
So
the-
here is
the-
a stent.
That's a stent.
Yeah.
Okay.
Now,
then-
if you go all the way distal, the stent is floating in the vessel. All
One
the
second,
way
1 second.
distal.
So yeah, some
Yeah.
possible malposition or some tissue between the stent strut and the native causal lesion.
Go all the way down, all
Yep.
the way down. Right here, see that?
Yeah, you're right.
It's floating.
So might be some malposition.
Not some. Entire vessel is,
But
not,
this is
not
many
from
years
cyanide.
ago. That's
Yeah.
many years ago. So I think, do you need to do anything now for that?
No, we
Yeah.
did. We
I
not.
think we just go to the ostium. I think we have 3.5 cutting balloon. We open
Did
the
he
cutting
ever have
balloon
an MI
and then
of
put a
RCA?
stent there. I think that's what we need to do, right? Let's ask our expert panelists and moderators what would they do. Let's go to the ostium again. This is the ostium.
So Dr. Sharma, this is a calcified nodule protruding possibly inside a stent.
Okay.
The tight lesion of the tight stenosis ostium is a calcified nodule here.
Okay. Get a 3.5. Yeah. Yeah. So we
3.5,
can
what
take
you want?
this one out. We are cutting 3.5.
No, why you want?
Yeah.
No?
IVL, no?
And looks like vessel
No,
size is
no,
more than
no,
4 low
cutting
vessel.
balloon, yeah. So
Blocks
3.5 flex or Wolverine.
No, SS, hold on. It's a 7 French.
Yeah.
You want to go 2 over? It's
Ostium.
ostium. We have a. Oh,
Yeah,
no, you cannot. We took out the rotor.
Yeah.
Out.
Yeah. So question
lesion
comes
length
yeah.
is very
short.
balloon
Yeah,
might-
very short. It's
Yeah.
true. Very short.
So let's take the Guideline out. We do,
Yeah.
I mean Guideliner, Guideliner,
No,
so
let's-
we can
let's keep
remove
it.
them now.
Yeah, 8 meter.
Let's keep
8
it.
Dr.
millimeter wide.
Ajay and Nagendra Bhupati has some point.
Yes. Yes.
No, I was saying that the lesion length is very short, so cutting balloon might work.
Yeah. Exactly.
Yeah.
That's-
Also, we have to be. I know it's a short lesion, but ostium. We were not able to assess the calcium that well, right, Kiski? Because many times ostial lesions not easy to actually have a good stent expansion. Let's see.
Why can't you take a caudal view boost?
Yeah. Go. Let's cut this. And this one actually the gay ostial. We can use the which is available in India also. The Megatron. It's a vessel outside is 3.5. I mean 4.5 or 4.
At least 4 low. A lot of calcium
4.
artifacts.
So
but
4
at
or
least 4 low
12
vessel.
or 16, 4 or 12 or 16 Megatron. So this is the ideal case with extra the connectors in the proximal segment and
Take out the Godzilla out later.
good.
Not going in. Okay, go up.
Flora, show it. So this is a 3.5
Can we move the?
Wolverine at yeah. We are going to the caudal view.
See,
It's not,
it's not opened yet.
Huh? Yeah.
I'm telling you, need a
So I know,
rotor.
but that's okay.
Or
Yeah,
I-
let's pull back
okay.
few millimeter. The question comes is that do you need to use IVL or your cutting balloon or high pressure balloon will do the trick?
No, you have to
You
need
can
something.
just inflate it, leave for a bit.
Move the camera.
Leave for a bit.
Yeah, exactly.
Stay for 15-20 seconds. It
That
might
is correct.
give way.
We can get a 4 or 15 high pressure balloon also. What is this? Yeah, okay.
Do we have an OPN around, Dr. Sharma?
Yeah, we do not have, we don't carry.
Okay, go.
Good. But yeah, so I think with these two of them, whether a cutting balloon, the flex tome or high pressure or IVL if necessary, we can be able to do it. Yeah, so good. It's looking okay. You have to just pull back few millimeter more.
Is that the ostium, Kiski?
Yeah, this is exactly osteo RCA.
Yeah.
And what is the circumference of the nodule?
Yeah, like here and here, but like 5 to 6 is not nodule. So combination.
So
Calcium plate
we are
and
saying
nodule.
a 2.5 quadrant.
I think so.
Massive nodule.
Yeah, true.
We actually presented our nodule management algorithm.
Yep.
You have it?
Last week.
It's
Slide.
just getting slipped distally.
No,
Yeah.
is
No,
it?
no. We are good. We are
No,
good.
We kept it there. It's at the ostium, cine. I
No, we're
deflate
good.
it here
Down.
and then we'll do the stent boost.
Come down.
Yeah. So just leave it there.
4, 5, 15. 4.
Just 1 second. Yeah. Okay.
No, I
We're
want to
going
pull
stent
back a
boost.
little bit.
Yeah, I know. But let's
Get
go
the
to,
IVUS. Swati,
Good.
get the IVS ready again. Go up.
Okay. You stand boost.
Huh?
You stand boost. Yeah, done.
Oh. Okay, go up.
That's it. The ostium, I can feel the calcium there.
Yeah.
Even on our
Yeah, see?
grainy
Yeah.
videos.
So
Okay,
we are
down,
nicely positioned. Yeah.
Go down. I'm
Yeah.
going to pull back more. Go up here.
Yeah, ostium could be very misleading. So what you do now, slow pressure to avoid the slippage. Slowly inflate.
Slippage is more common when you have intimal hyperplasia, not so much with the calcium.
Yeah. See, I think this is a good opening. We are at 16 atmosphere and we are going to leave it for about 30 seconds.
Okay, down.
Yeah.
Leave it a few seconds.
IVS is ready. Okay.
So sometimes we pull the balloon back, rotate it 45 degrees,
we
go
did,
back.
yeah, we did two
Yeah,
times.
we did it already.
Yeah, a few times. So let's do once again. Yeah.
Because you find the weakest point in the calcium ring to crack with that.
So now with the repeat IVS, what are you going to see?
I will see if this cutting balloon has done anything, or do we need need anything more than that?
And more
So
than that
suppose-
could be, yeah.
More than that, likely I will tell you. Do we need to
IVL.
go? Likely will be IVL with having done all this.
You like a,
Suppose we-
get ready
Oh,
for
Can
IVL,
you,
but don't
do you
open
have
it yet.
that algorithm stent? I mean nodule.
Let's do the IVS 1 second.
After this, I'm going to remove the Godzilla out. Hold it. Right. Okay, good. The biggest learning point, for everybody is that which it should be the mode of calcific modification, especially when you see a calcium nodule.
Okay,
And that is what we presented and published. We presented in ESC and we have published, and hopefully we'll find the slide right now.
Yeah.
Okay, good.
Beta lumen.
Okay, now go back,
Yep.
right?
At the ostium here, the level of the aorta going, yeah, here. It was like area was 2.2. Now it's more than like 4.9. Yeah, actually it's a much bigger lumen.
Sure.
No,
Of course,
lumen
they-
is big, but did
to
we
show those light
do
slides. The
anything
first
to
one
the
first.
So
nodule
by
as
the
such?
IVS resolution, it's tough to say is a big fracture or not. But at least lumen is like more than double.
Oh, definitely lumen has become big.
Yes, yes.
No. That's not the thing, SS. We have to make sure that something has happened to the nodule. Otherwise, stent
Anyway,
expansion may not be the best.
happened. And a very focal lesion. I think it
Yeah.
can go stand and post-irritation.
I think beautiful image, nice size. But I think good idea to go with a 4-row NC balloon and see if it expands on stent boost before putting
Yes.
the stent. If it doesn't, I think
No, you will see it. It will show that it is expanded, or you see it already here, even when you did your cutting balloon.
But we can do
That's
with a
all.
regular balloon also. Yeah.
It's-
And show show that slide down 1 second with your the nodule algorithm, which we published. If you show that slide,
You want to do NC balloon
we can do it. So okay, this is you want to
or
start.
IVL?
Yeah.
4-row IVL.
No IVL. In the cutting balloon. Oh, yeah. Talk about nodule you wanted.
Yes. So we can see that this is the that was published. Actually, Kiski presented it ESC almost close to late breaker. So if you see angiographically moderate to severe calcium, at that time you can do intravascular imaging. In this case, we could not do the intravascular imaging because of various reasons, but later on we were able to do the intravascular imaging. So when you're not able to do the intravascular imaging, and that's the same case that was happened during the India Live, that they wanted imaging, we could not get the catheter down the intravascular imaging, in that situation, it's already telling us either it's calcium and tortuosity. So then you go up front, RA and OA, whatever people would love to. And after that, you can do the intravascular imaging to understand the calcium. So you've seen the nodule. Of course, OCT is probably the best, but then we are not able to do OCT in many of the cases. And then you will understand the nodule. The majority of the time, the nodule we see, I would say 70% of the time, is non-eruptive rather than eruptive. What we created was the next level of the algorithm. What is, once you see a nodule, okay, then you need to see what is a calcium plate around the nodule. Like in this case, right?
Yep.
The nodule itself was large. We didn't have a lot of cases, but otherwise, even if it's a large nodule, and then is there calcium plate around that? Is there the calcium plate of more than 100 and 270 or less than 270? Essentially, it's telling you, even if there's a nodule, the calcium plate around the nodule is the one that is not going to allow you the stent to expand.
Not able to.
And what is important is MLD at the level of the nodule. Here MLD was okay, but if MLD is smaller, then again, you know, if you did imaging, then you consider rota, OA, and then plus minus IVL. So essentially, one calcium nodule, two the amount of, you know, the calcium around the nodule. If it's a no, very simple, you can do high pressure balloon. If your MLD is really high, you can probably go with IVL rather than rota or OA as a first line therapy.
So this is basically is that the MLD based on, then you decide whether you need to go with the rotablation or you just do with the high pressure balloon and so. So this is where we are done now.
What did you do?
Ready with the fluoro? Go back to fluoro now. Yeah.
Did you do high pressure?
Yeah, here. So this is now 4O NC at 20 atmosphere. I think it's reasonably expanded. And we are ready for now with the put a Megatron. We are coming to the end of it. 4O 16 Megatron. Yeah, let's get a 4O 16 Megatron. Huh?
Very well
12
explained.
or 20? Which one you want?
12.
12, yeah. Very well expanded. And we do this, show it, and get ready for our presentation. We are right exactly at the time. Lot of imaging discussion.
But I still, I mean, we don't have the data. Hopefully we'll have enough imaging and more of, because we are going to start as our in-house trial to understand the treatment for nodule. Because I know we have done as much as possible here right now for this case, but is there a risk of restenosis exactly the way the eruptive nodules behave? Because we know eruptive nodule, at the time of the intervention, your MSA is very good, but somehow they come back. Would this be a case like that? Because this nodule, you saw that was more than 2 quadrant, almost 2.5 quadrant.
Good. This looks good.
Oh. Okay, wait.
Yeah.
No, what?
Is the
Like-
Godzilla there still?
No, we moved it out. I thought we had moved
Yeah.
No?
Okay, so some die. I'll see. Ready for the IVUS again?
Yeah, they'll be ready.
A cuspal wire will be more easy to
Good.
place the stent.
What
Ready.
are they saying, Bhai?
No good. Deploying now.
A cuspal wire in the cusp.
No.
yeah.
I would never do that.
We used to do that quite a
Please.
bit. I think the once you have
I will explain.
imaging,
Yeah. Please, ready?
deploy.
No, take a picture
Okay.
again because earlier was not. Okay, I think we are
Keeping the
good.
wire
Yeah.
in the ostium gives you a false assurance.
Yeah, exactly.
Yeah, 100%
Yeah.
and depends on where your guide is. If your guide is too much,
Going up.
yeah, go up. We used to call it a modified Zebo technique.
No, modified Zebo is you're going
No,
to the stent.
Zebo was you put the wire through the stent.
Yeah,
Yeah, modified is.
just
but
wire
you,
in the sinus.
You used to do it, yeah.
Yeah. Now pull back few millimeters. Yeah,
Okay, good.
kind of little flare.
I was ready. No, no, I think we don't need to. You want to post again?
No. Let's see
I think we did a good job. You don't need too much post.
Yeah, good.
Okay, let's do the IVAS.
Yep.
Right?
Hours and we call for the day. Good.
Do you think is it okay to go inside and dilate the Malapo stent since we have 4O balloon there?
Well, my question is, Bhupati.
No.
Because remember that stent has
You
been
don't
placed
even
for
know the size of the stent.
16.
Yeah.
Now, why do you want to create a new intimal injury? We remember right now, this is so many years ago. So injury, in the intimal injury we create now, then the whole process will start. That area did not re-stenose. But you are right. If there is some intimal hyperplasia, then yes, the lumen was very good. And that the region would be that don't touch it now, because anytime you do some injury to that stent, you will start the process of re-stenosis, which we don't want to do. So that will be the logic behind. So now question is, you are right.
Yes.
Delayed 2-3 years maybe, but this is now 7-8 years ago. The stent was placed. Patient has a RCA stent. After that has a chest pain and then went for the Lima to LAD. RCA was good at the time of the Lima.
So in cut short, the previous operator did a proximal RCA stent. It was not in the ostium.
Okay,
or
check
it
the
was
image.
in the ostium over a period of time by
Guide
injury.
is
You
out.
have pushed the
Okay, start fullback.
stent ahead.
That is correct, yes.
Hmm?
Good. Nothing.
Previous
No,
stand.
please. Oh.
Good.
New stand. Yeah, well expanded. Yeah, cover the ostium. Yeah, looks very
Nicely
All right.
covered.
Wow.
very good.
Full dot.
Okay, show the last one. Yeah,
Sure. There's a level of aorta.
we'll take the last
Exactly ostium. Yeah.
Yeah.
Area is like 13.
picture. Okay, now go to
So
the...
ostium well covered
Covered. Yeah.
on the dot.
Yeah.
Yes.
This is the level of the aorta. It's
Yeah.
covered.
Beautiful. Look at that.
Yes.
Wow.
Very
So
excited.
this is the true rotacut approach, plaque modification. Let's take a last picture there. And then we have to go back up and, yes, just in it. That's good.
Wait, 1 second.
Yeah. You want to do a low mag?
Position, no
Yeah.
dissection.
Good.
Looks perfect.
Oh,
Ready?
I hope so. Ready?
Yep.
Good.
Beautiful. Good. And if everybody is okay, looks very good, imaging wise, angiography wise.
Last question for you, Dr. SS.
Yes.
When do you think you will go for orbital atherectomy? The one couple of indications or no indication at all?
Yeah. No, I would say that orbital atherectomy now, overall, in my opinion, although there is a lot of pressure now I got from India, so people will still want to use orbital atherectomy. In America, use has become less than 1% since October, November. But they apparently in India still big enthusiasm. So they have asked me to duplicate same, the meet the master and teach them O square. Orbital atherectomy guided with OCT. So yes, so question is, orbital atherectomy can be used anywhere when you want to use a rotablation. And of course, in a large vessel, by two different speed, it may be a just single answer rather than doing upgrading the bar. Now, ostial lesion, I would say be against it, but although a lot of people say that you can manually advance and then reverse back. To me, you did a daughter. That means you don't need the atherectomy for that purpose. So orbital and so. So I would say that yes, orbital, if that is what people want to use, where is the advantage of the orbital? Biggest would be that it causes less hemodynamic instability. We cannot say now that it caused less slow flow, because remember Eclipse trial, the only trial of atherectomy which showed higher slow flow with the orbital compared to the contemporary comparator arm with the balloon angioplasty. Every trial of the rotational atherectomy, Rotexas, prepare calcium. There was no difference in slow flow with a rotablation versus a non-rotablation approach. So therefore, I would be careful claiming that it, then also we cannot claim it caused less perforation. Every trial, Rotexas prepare calcium, there was not a higher perforation rate. Of course, in the Eclipse trial, it was not a significantly higher, but numerically was almost double perforation rate in the orbital atherectomy group. So I think the orbital atherectomy, in my opinion, would be that large vessel where you want to go up to 120 and it's not a tortuous vessel, that will be the indication. So what advantage will it have over rotational atherectomy? Let's say you have both. Which particular case you are going to use orbital? I think it's very tough to say that any particular lesion preference for the orbital. Now, I think maybe we can say hemodynamic instability, very long lesion, that orbital by slowly passing will be able to do a little better job, but those all is small theoretical. There is only one trial comparing called DERO trial, and DERO trial showed your stent opposition, stent expansion, plaque modification was better with a rotational atherectomy compared to orbital atherectomy. But having said that, until the device is taken off the market, we don't even know what will be the future. Although Abbott is still very gung-ho and continue find the new indication for orbital, and we'll be doing few cases for our different type for our India Live cases here, just like we are doing Rota for last 3 years, because people want to use it. We'll try to teach the good steps without causing any slow flow or dissection. That's what we see in our lab. All right.
The only study comparing orbit versus rotablation from Sinai image-based clearly showed that orbit causes burrows while rota actually cuts. It was scary to look at those OCT images.
OCT definitely cuts deep wall, which is Anu did very early.
No. OA does deep cuts.
Yeah, that's an orbital deep cuts, and but then the randomized trial, that was our we just did a descriptive study of 20 cases, but randomized trial is only the DERO. But the point is the DERO trial was more of a imaging study. Outcome was not different, but 50-50 patient, very small trial. Okay, with that note, if everybody is okay, Dr. Rahman, if you can start the presentation, I'll join you in about 5 minutes. And thank you, everyone.
That was the great cases. Thank you, Dr. Sharma.